Okay, good morning to everybody. Thank you for your kind invitation, and I also appreciated the initial evening meeting yesterday, so I had the chance to to appreciate your warm hospitality. Thanks to Professor Will for inviting me to this meeting, as well as the local management and professors. And I'm happy to contribute any way I can in this course or possibly over the next courses, if that's the case, to the cause of development of fetal medicine in Hanoi and in your hospital in particular. If I can have the lights down, please. So I was requested to talk about the fetal heart and to present two talks. The first one is addressing the issue of ventricular disproportion. And the lights, please. Can you get the lights down? Okay, a bit more. Anyway, let's start. So the first question is, because otherwise people cannot see the screen properly. That's the only issue. So you can switch off the lights here. Okay. So what is mild? What is ventricular disproportion? You can go in a subjective way. Yeah, thank you. Saying that you have a mild ventricular disproportion or moderate or evident, I would say, ventricular disproportion or extremely severe ventricular disproportion. This is a way to go by eyeball and to assess in terms of subjective evaluation what is ventricular disproportion. The other way is whether you want to measure anything. If you are not an expert in fetal heart, I strongly recommend anybody not to measure anything, because otherwise that's the best way to create false positive diagnosis, okay? So having said that, if we consider that there is a slight prevalence of the right heart on the left heart, which is normal, especially in the third trimester, and we put this ratio in 1.3, and if we say that overt disproportion is anything that is beyond 2, saying that the right heart structures are twice as large as left heart structures, so anything in between may be considered to be moderate ventricular disproportion. That's not an official classification. That's a personal way to suggest you how to move and how to make this kind of diagnosis. Okay, so the bottom line again is, however, if you do not, if you are not an expert, not to measure anything, just get around the heart, assess it from different approaches, and if the impression persists, then refer the case for fetal echo. Then, if you have a case referred for ventricular disproportion, what you should mind to check as possible causes of ventricular disproportion. There are two major heart abnormalities that may be associated with the heart disproportion. The first one, which is the rarest one also, is the total abnormal pulmonary venous return. So to exclude this, you should at least see 2 pulmonary veins out of the 4 entering the posterior wall of the left atrium. And then we will expand on any of all these lines. The second one is whether there is any evidence of a dilation of the coronary sinus. The third one is the possible presence of aortic coarctation that you are very well aware of. And the fourth one, which is the last which has been added recently by our group, is whether there is a redundant flap of the foramen ovale. So let's start to approach any of these lines. The first one is to see 2 pulmonary veins entering the posterior wall of the left atrium. This is a bit more tricky in the second trimester. is much more evident in the third trimester. And as far as screening is concerned, you may be happy just with the grayscale appearance, or you may complement it with the color Doppler. And the more recent glossy color Doppler, very highly sensitive color Doppler, which allows you to depict with no effort two pulmonary veins entering in the posterior wall of the left atrium. This is the appearance that you should seek and should be there. Sometimes you, with a slight twist of your transducer, you can also show the 4 pulmonary veins entering in the posterior wall of the left atrium. The aim of this assessment is to exclude this type of image, in which you see that you do see the pulmonary veins, but they meet behind the wall of the left atrium, and there is no connection at all with left atrium. And see how thin is this, the strands of tissue which separates the posterior wall of the left atrium from the pulmonary veins. So it's very challenging to pick up this kind of anomaly. But definitely total abdominal pulmonary veins return is one anomaly that can be associated with ventricular disproportion. A minor abnormality which is also associated with ventricular disproportion is a dilation of the coronary sinus. The coronary sinus in normal hearts is barely visible because it's a structure which is just on the top of the mitral valve. And you pick it up only when there is a minor or more evident dilatation of this structure, as you see here. But the degree of dilatation may vary. You see here that you have this ring, which is consistent with the dilated coronary sinus, which is slightly dilated. On some other occasions, you see here, it's more significantly dilated. And very rarely, you have a huge coronary sinus that you see here. So the size of the coronary sinus, dilation of the coronary sinus may vary according to some conditions that I'll show you now. First of all, an embryologic remainder. What happens in the normal heart during development is that on the left side, you have regression of this vein here, and you have development of the brachiocephalic vein, so that the blood coming back from the left jugular vein from the head reaches eventually the right-sided superior vena cava. If this is not occurring, then you have persistence of the left superior vena cava. And of course, since the amount of blood which passes through the coronary sinus will increase dramatically, because it will be half of the blood coming back from the head, then the dilation of the coronary sinus is significant. At the same time, you do not have the development of the brachiocephalic veins. And this is another image taken from the net. This is a normal size of the coronary sinus. And this is a dilation of the coronary sinus because you have the left superior vena cava, which is draining straight into it. So what are the differences in these 3 images? If you have persistence of the left superior vena cava, which you find on the 3-vessel view, just lateral to the pulmonary trunk, as you see here, in addition to the normal right-sided superior vena cava, then you have moderate dilation of this structure here. If you have on the other side persistence of the left-sided superior vena cava without any hint of a right-sided one, then this means that the whole of the blood coming back from the head of the baby will return to the heart through this vessel. And this is why, in this case, the dilation is much more evident than in this case. And on very rare occasions, you have another condition. It may occur also in isomerism. And you see here the azygos vein close to the aorta, in which you have not only the left superior vena cava draining into the coronary sinus, but also the blood from the azygos vein, the azygos continuation. So also part of the blood coming back from the lower part of the body reaches the heart through the coronary sinus. And then the real question is why the coronary sinus determines ventricular disproportion. And this is explained to you thanks to this clip. This is a reconstruction using the sonar AVC, which is a technique developed by one of the producer of the scanners. And each cardiac structure is in different color. Number 6 is the left superior vena cava and draining into the coronary sinus. Number 3 is the right atrium, right ventricle, left atrium, and left ventricle. And now I turn the volume and see what happens. This is the okay. This is the superior vena cava. This is the coronary sinus, and you see that it's extrinsic constrictions along the mitral inflow. The purple one is the left atrium, and this is why you have this kind of very severe reduction of the inflow, because the inflow of the mitral valve is reduced, and this brings along ventricular disproportion in this case. And it's not the case that the presence of a superior vena cava increases the risk of aortic coarctation. So you may have two different conditions at the same time, which are associated with prevalence of the right heart structures. Another condition which we described recently is a redundance of the foramen ovale flap. In the normal heart, usually the flap does not extend beyond half the way between the interatrial septum and the lateral wall. On some occasions, you have this kind of very redundant flap, but with no ventricular disproportion. But if the redundancy increases, as you see here, you may start to have ventricular disproportion. Look at the two atria. They are quite different in size. And in some rare cases, you see also that the flap, which is so redundant, gets stuck into the foramen ovale itself. So contributing to the shift of blood from the left heart to the right heart. And this is why you get this disproportion. And in fact, the mechanism is that you have dynamic obstruction of the mitral inflow, plus a perturbance of flow, of the streaming of the flow from the ductus venosus through the foramen ovale to the left atrium, because the flap of the foramen ovale is redundant. And this will in turn reduce the blood flow across the left heart and increase the blood flow in the right heart. And this is why you have this vicious circle, which leads to ventricular disproportion and may mimic aortic coarctation. In fact, you see here in one such case in which there is a ventricular disproportion in the third trimester, look at the wide flap of the foramen ovale, and you see how narrow is the inflow to the mitral valve in comparison to the one to the tricuspid valve. And this is due to the fact that the bulging of the flap of the foramen ovale was obstructing the mitral inflow. And in this case, you see here that on the trivessel view, you had significant discrepant sides of the aortic isthmus versus the ductal arch, also with turbulent blood flow that you see here. So this condition may mimic aortic coarctation. So in any case in which you have the suspicion of aortic coarctation, go back to the four-chamber view to assess the flap of the foramen ovale, because if you see that, then the chances of having aortic coarctation is indeed reduced. And then we come to the condition which is usually associated in most of the cases with ventricular disproportion, and this is aortic coarctation. Aortic coarctation may occur as a single shelf or as a long tubular hypoplasia of the whole transverse aortic arch, as you see here. In comparison with the normal heart, the indirect signs that point you to the presence of an aortic coarctation are very easily picked up in severe cases. For example, in this case, in the second trimester, it's quite clear-cut that you have ventricular disproportion. And in those cases, as I'll show you in a while, if you go to the three-vessel view, the evidence of the aortic coarctation will be there. But some cases you have challenging diagnosis because this was a perfectly normal heart in the second trimester. And only in the third trimester, you could see this moderate ventricular disproportion. And eventually, this baby was diagnosed at birth with aortic coarctation. So there may be subtle signs there to be picked up for you. The situation is also very challenging because sometimes you have normal appearance on the fourth chamber view, because you see that this was taken from a stick volume so that you can explore one plane after the other. And the fourth chamber view was actually unremarkable. And if you look separately at the left outflow tract, you would say that these were normal outflow tracts, which is correct. But if you compare them on a three-vessel and trachea view, you see here that the sides of the isthmus was as small, almost as the superior vena cava. So there was
cái bất tương xứng giữa quai của động mạch chủ nó rất là rõ ràng.
Coarctation. And this is why sometimes it's not enough to look at the fourth chamber view for this kind of disproportion, but you should also try your best to compare the two outflow tracts, because in some cases, you have only disproportion at that level, pointing to an underlying aortic coarctation. And then, of course, the direct diagnosis is made on the three-vessel view. You need color, and you should aim to see the V shape of the ductal and aortic arch, which have the same color and same thickness, okay? And then you have evident ventricular disproportion, evident aortic coarctation in this case, in which the sides of the aortic arch is much smaller than the ductal arch. Extremely severe one in which you can barely pick up the aortic arch, which is here, or you may have the tubular hypoplasia with a very, very narrow isthmic course here with reverse blood flow. And this is the typical appearance of severe aortic coarctation, which is associated with hypoplastic left heart syndrome. This was the specimen associated with this image here. This is the tiny arch, is this one. You may use power Doppler because they are more sensitive and feel better the cavities to demonstrate the arrangement with three-dimensional imaging with the stick. In this case, it's a normal case, which is the normal arrangement is that you have the three neck vessels here. That's the aortic arch, which is normal. And then you have the ductus, which is inserting onto the aortic arch. This is a normal appearance. In some other cases of clear-cut aortic coarctation, you have all the signs, so there's virtually no doubt that this baby has aortic coarctation. This is the tiny arch, and you see that in severe cases, it's also higher than the ductal arch. It's called tapering of the aortic arch. And also you see that the flow across the aortic arch does not disappear during diastole, as does the ductal flow. So that's turbulent flow. So you have turbulent flow, small arch, tapering of the arch. That's a clear-cut coarctation. But sometimes you have the use of stick and three-dimensional cast of the aortic arch helps you to find the subtle cases which are quite challenging. In this case, the arch looks normal, but you see here that you have a posterior shelf and the restriction of the aortic arch at this level, only on the posterior part. And this was confirmed to be an aortic coarctation. Nowadays, again, with these very new sensitive tools associated with high frequency transducers, also in two-dimensional imaging, you can assess very thoroughly the arch and the ductal arch. And so the diagnostic role of stick and of four-dimensional echocardiography is slightly reduced in comparison with 10 years ago. As far as coarctation is concerned, another of the main key sign is the fact that you have turbulent flow. Turbulent flow is shown on spectral Doppler by the persistence, which the pediatric cardiology call diastolic tail of flow during diastole. This is the normal appearance for isthmic flow, and this is turbulent flow, which I showed you also on the clip before on power Doppler. What are the tools that you have to diagnose, to predict actually the presence of aortic coarctation? One of the few ones that we use together with the turbulent flow is the zeta scores of the aortic isthmus, which was described several years ago by Lina Gardiner. And this tool allows you to separate actually those with this narrow arch from the normals. But still, you cannot predict which one is going to surgery and which one needs to be just followed up. And the other major finding is the flow disturbance, which per se, turbulent flow is one of the major signs of aortic coarctation. But are we able to predict aortic coarctation? Well, no. I share the same conclusion that Lindsay Allen was reporting more than 30 years ago, actually. The most severe forms are consistent with the second trimester diagnosis. We do not have any trouble in finding them. The challenges regard those who are consistent with the normal early fetal echo. At that time, early meant second trimester. And this is also very true today. In late pregnancy, it's virtually impossible to exclude aortic coarctation categorically. A very high number of unconfirmed diagnoses. Another paper, which is, I think, also very useful, was published by Korean group several years ago, and they compared the left and right structures, and in the graphs, all the red dots are the true positives, and all the blue dots that most of the false positives were occurring late in gestation, okay? So this means, and their conclusion was that for a case referred in the third trimester for moderate ventricular disproportion, there is an 86% chance of the heart to be normal. That's quite important because this is the number and the figure we use in our counseling for those patients. So the conclusion for aortic coarctation is that the diagnosis of severe cases is relatively straightforward. The one of less severe or late onset cases remains challenging nowadays. And we use this figure of 10 to 15% chance of having a coarctation for those cases who are referred late to our group, and which you still need to centralize the delivery, because if you end up with a coarctation, that's neonatal emergency. So the baby needs to be operated within 48, 72 hours of life. They need prostaglandin infusion until that time. And so you have to centralize all these patients for proper diagnosis and management of the neonatal cause. Stick may help, less so much so than in the past, before the introduction in clinical practice of the high-frequency transducer and the new class of very sensitive color and power Dopplers I showed you before. And as far as the conclusion of this first talk these are that when you have ventricular disproportion, you have to exclude these conditions, to which I should add also a late onset one that for the sake of time I skipped, which is the restriction or closure of the ductus arteriosus. And consider, that's the bottom line, that for moderate ventricular disproportion, this may be a very normal finding in the third trimester in most of the cases. So that's quite important for you and during counseling with your couples. Thank you for your attention. So now somebody helped me because we decided yesterday night to take in some questions, but I'm not sure if this is the case or you want me to move on. Toan or anybody can. Shall we leave the discussion for later or continue? Okay. Okay, so we continue and leave the discussion for the two talks at the end and Q&A session. The second talk of mine is is there any way for non-expert to predict what is the actual prognosis for a fetus with congenital heart disease? Not because non-experts should carry out the counseling, that's not the message, but because you know that by experience that the first words that are told to the patient or to the couple after the initial recognition of the problem stick in their mind, and it's very challenging and difficult to remove them, also with thorough counseling, multidisciplinary counseling afterwards. So if you see a patient with a heart problem and you utter the wrong words, this may lead to an unnecessary termination of pregnancy on one side or the other way around. So this is quite important for you to consider the issue of how to make a prognosis. And also for those of you who are not working with pediatric cardiologists and geneticists, so not have all the informations, that's quite important for you to consider what are the key points to consider to make a prognosis. Let's start from the genetics. You know that 10–20% risk in general of association with chromosomal anomalies is mentioned for heart problems in general, congenital heart disease in problems. And most of these are the autosomal trisomies as well as Turner syndrome. And of course, you are very well, or should be very aware of the fact that all these are sharply decreasing nowadays in the second trimester, thanks to the high sensitivity of the first trimester screening, be it combined test or more recently the introduction of cell-free DNA testing. So in percentage, all these are sharply decreasing. And of course, this means that if you have a genetic problem in this baby, nowadays it's much more likely to have unusual and rarer conditions that you could imagine in the past. Nowadays, in I think all over Europe and all the places where you have widespread cell-free DNA screening, it's very rare to see a atrioventricular septal defect in the second trimester associated with Down syndrome, just because you have eliminated all the cases of Down syndrome with this kind of screening and leading to termination. And in fact, if you go by numbers, and I did this kind of very simple exercise, if your detection rate before the introduction of the combined test, 65% of all the cases of complete atrioventricular septal defect, I set the point that before the year 2000, were associated with Down syndrome, which is the yellowish, egg yellowish part here. Then you have the introduction of the combined test, the nuclear translucency screening, which on the lower end has a diagnostic detection rate of 80%. So you deduct those numbers from the ones I mentioned before, and you end up with an association rate of 50%. So after the introduction of the combined test, 50% of the complete atrioventricular septal defect could be associated with Down syndrome. And if you consider the more recently higher performance of cell-free DNA, which together with high quality combined tests exceed 95% altogether, 99 for the cell-free DNA. So after 2013, only 5 to 10% of all the atrioventricular septal defects that you see in the second trimester and beyond are indeed associated with Down syndrome. So this means that the same atrioventricular septal defect, which when I trained was a kind of Pavlov reflex saying, okay, you have an AVSD, that's the baby is down, doesn't work anymore at all. So if there is any chance of that baby to have another genetic condition, would be deletion 8p, terminal, or any other condition, but not Down syndrome. Then you have to consider the non-chromosomal abnormalities, which may be associated with the congenital heart defects. And for example, we have here the cardiac rhabdomyomata. And in this case, of course, you should consider that there is a 90% chance of being associated with tuberous sclerosis. And if you are in the third trimester and you go with a transvaginal approach, you see all the tubers at the level of the brain, and you can confirm the diagnosis also without carrying out an NGS test afterwards. And these are two cases with the tubers all over the brain. Or you may have, for example, conditions that are associated indeed with genetic conditions such as cardiac rhabdomyoma, but in which the prognosis is complicated not only by the association itself, but also by the actual development of problems with the lesion itself. For example, in this case, you have a huge rhabdomyoma, which was obstructing the left atrial tract and creating at the same time bradyarrhythmia and heart block. And this is why it was developing heart failure in utero. So you have not only genetic problems, but you have to take care also of cardiac problems in these conditions, which may lead to fetal demise earlier. And then we move, for example, for group of conditions which have an association with microdeletion 22q11, conotruncal abnormalities. In this case, the major risk indeed is the presence of microdeletion 22q11, okay? And in this case, you have a thymus hypoplasia, which may be a marker of the conditions. And this is a normal thymus in the third trimester, and this is a very hypoplastic thymus in a fetus with confirmed microdeletion. The thymus, you should consider that is absent or significant hypoplastic in 1/3 of the patient of the microdeletion, but in the overwhelming majority of the cases with the full form of the microdeletion, which is the George syndrome. But consider that you may have thymus hypoplasia also in other conditions, which has nothing to do with the conotruncal malformations. And then we come to the cardiac factors. Now we analyze all the segments of the heart and try to decide whether it's a good prognostic factor or is a bad prognostic factor. First of all, we should consider that the heart is the engine of the ventricles are the engines of the heart. So in any case in which you may expect both ventricles to be used in the reconstruction, for example, here you have the trilogy of Fallot, or any case in which you have both ventricles which are normally contracting, you have a good prognosis. Versus those conditions in which you have one ventricle which is not working at all. And in this case, you have an HLH, apoplastic left heart syndrome. And mind that I will show you an HLH on several of these slides, because unfortunately, this is one of the worst conditions ever in which a series of anomalies are associated, and this is still today one of the worst prognoses for the heart. If you have an apoplastic ventricle, does it matter whether it is on the left or the right? Yet it does, because the systemic ventricle after birth is the left one. So if I were to choose, I would prefer not to have the right ventricle and to keep the left ventricle functioning. So if you have, for example, pulmonary hypoplasia with hypoplastic ventricle versus an HLH, of course, this will do better, much better than this. If you should cite any figure for pediatric cardiology textbook, in this condition, overall, you have survival rates of 80%, 70%. And in this case, with the exception of a very selected series in America, you have survival rates of 30%. And then we go to the outflow tracts. Again, it's better if you have both outflow tracts present, and it's worse if you have one outflow tract which is absent. So for example, in this case, you have transposition of the great arteries with two patent and normal size outflow tracts. And in this case, again, as an example, I put hypoplastic left heart syndrome because you have aortic atresia and the whole of the aortic ascending aorta and the aortic arch is severely hypoplastic and virtually non-usable for reconstruction. And then you have, if you have to choose again what outflow tract you would prefer to have, again, it's better to have the aorta than to have the pulmonary artery. If you have the aorta, again, survival rate is higher in higher quality of life. If you do not have the aorta, and again, you have hypoplastic left heart syndrome here, survival is much lower, and the amount of the quality of life is much worse. And then you come to the issue of neonatal emergency. Of course, it's better if you have those conditions which can deliver also in local hospital, for example, tetralogy of Fallot with the only moderate obstruction of pulmonary outflow tract, or atrioventricular septal defect or ventricular septal defect. All these conditions do not need to be centralized for delivery, whereas all the conditions which need a painted ductus arteriosus to survive and to reach in stable conditions the cardiac surgery are to be considered neonatal emergencies. And these are all the obstructions of the left or the right heart, as well as transposition of the great arteries that you see here. And all these cases should be centralized, get a neutral transport to referral center where you have a neonatal intensive care unit, cardiac catheterization unit, and as well as cardiac surgery. So you have to take care of all these factors which are related to the cardiac lesion itself. But then the baby, the fetus is in the womb, and so you have to take care also of some other conditions and also of some subtype of conditions regarding the cardiac diagnosis. For example, you have here apoplastic left heart, which is a very severe condition. But if you have a patent foramen ovale flap, that remains a neonatal emergency, but is manageable. If you have a closed foramen ovale in the setting of apoplastic left heart, this is a critical condition which may lead to intrauterine demise as well, or very early demise despite prenatal diagnosis. And in fact, in some cases, it has been attempted to perforate with a balloon to make a Rushkin procedure in utero to relieve this condition. For example, if you have double outer right ventricle, and again, in this case, it's better to have two patent outflow tracts than having only one. In this case, you have still a double outer right ventricle, but you have the aorta, which is patent here, and a very, very tiny pulmonary artery on the other side. So that's another crucial point to take care of. And also, you have to consider whether you have any insufficiency, major insufficiency of the valves, because that's a major negative prognostic features, because the fetus tolerates much better the atresia of the valve rather than the volume overload created by the regurgitation of the valve. You see here, in case of tetralogy of Fallot with absent pulmonary valve syndrome, you have these to and fro movements of the fetal blood, which provides the room for cardiac decompensation in utero or after birth. In addition to the fact that this compression on the trachea may lead to tracheomalacia in these cases. And of course, one of the major signs is whether any condition occurs in situs solitus or whether it is associated with the cardiosplenic syndromes. In this case, you have two very similar cases of atrioventricular septal defect. In this case was situs solitus. In this case, you see the azygos continuation here. So there was a sign of an underlying isomerism. And of course, whatever is the lesion, if it is associated with cardiosplenic syndrome, the outcome will be much worse. And again, as I was saying before, the volume overload is very important because the fetus tolerates much better the pressure overload rather than the ventricle, the volume overload. And I showed you before the absent pulmonary valve syndrome. And this case is pulmonary atresia plus intact ventricular septum, and it's much better tolerated this kind of minor degree of tricuspid regurgitation than a massive regurgitation, which is associated with severe dysplasia of the tricuspid valve. And this is also related to the degree of how to assess the degree of regurgitation. You have very trivial blue dots here, which is not clinically relevant. Mild regurgitation only here. More severe evidence of regurgitation. This is again an intermediate type of the ventricular septal defect. And severe regurgitation, in this case, which was associated with bradycardia and isomerism. And take into consideration also the progression of the conditions. For example, there are some conditions, critical aortic stenosis, that may change for the worse. And it has been described that this condition, in half of the cases, will transform into an apoplastic left ventricle. So in this case, you cannot any longer use the left ventricle for reconstruction. And this is the rationale for in utero valvuloplasty, which has been carried out. Also, our group has done a few of them. A few because the selection criteria are very strict, and most patients in Europe do terminate a pregnancy for critical aortic stenosis. So the numbers are really small in comparison with the USA, where most of the centers are doing this type of procedures. And then you have evolution and progression from valve stenosis, in which the cusps of the leaflet are opening indeed, to valve atresia, in which they get sealed and you do not have any blood flow across the valve anymore. But you see that in this case, since the trunk, the sides of the trunk was kept and was maintained decent, then you can, that doesn't affect the prognosis because you just carry out the valvuloplasty after perforation, and the prognosis is very similar to this condition here. And then you have all the factors, and I'm wrapping up the conclusion, related to pregnancy, because the fetus is, as I was saying you before, in the womb. So you have to consider also during counseling, for example, if you have twins, that what you mention in terms of figure for survivals and so on and so forth are related to a term delivery. If you have an issue with preterm delivery, it does change completely the scenario, because below 2 kilos, every surgery is much more lethal, I would say. And some conditions cannot even be approached because of the different pressures that you have in the lungs. There is the issue of the IUGR, which is associated with some condition, also with the normal karyotype. For example, coarctation of the aorta may be associated with the IUGR, and that's another issue. Again, I was telling you about singletons, mono versus dichorionic, because in this case you have an increased risk of right heart lesions, but at the same time, you have an increased risk of preterm delivery, which is much higher than in di or in singletons. And of course, if you carry out a prenatal diagnosis of a neonatal emergency, and so that the baby can be delivered at central hospital or not, where the baby has to undergo transportation, neonatal transportation of a very critically ill neonates. And finally, also the issue which has arisen recently in the literature of the brain, of the supply of the oxygen to the fetal brain, because this is impaired in a series of conditions, mostly in univentricular heart's anatomy. And this is associated not only with the evidence of delayed brain maturation, but also with the increased risk of neurodevelopmental delay, especially for left-sided lesions. And this is why ISWAG has carried out and has written a consensus. And the key points are, first, that nowadays you cannot carry out only karyotype and not even a CGHR rate in most of the cases, but the higher the number of publication, the more the need arises also for an exome sequencing in case also for isolated cardiac leaflets in the fetus. Second, that the evidence is there that HLH and all univentricular association are indeed associated with neurodevelopmental delay in a percentage of 35 to 40%, and this is independent of the risk of hypoxic period during surgery. And this is highly recommended to mention this in the prenatal counseling. For other conditions, including transposition, there is a completely different position of the pediatric cardiologist overseas, meaning in America, which they mention this risk to the patient because they do not fear that the patient may decide for termination. In Europe, all over Europe, this risk, especially for transposition, was not considered to be so important as for univentricular heart. So nowadays, there are a lot of studies ongoing to assess whether there is indeed a risk of neurodevelopmental delay, which is significant for transposition as well. In the meantime, and this is the last part of my talk, this is the way to bring the issue of neurodevelopmental delay for congenital heart disease to the patient that you have in front of you in a way which is gentle enough and rational enough not to lead to an unnecessary termination, increase in termination rates for these conditions. This is what we do nowadays, I think mostly in Europe. And thank you for your attention. So what comes next? Questions or there's Mark talks? I'm not.
Alo, xin mời các quý vị đồng nghiệp chúng ta đặt câu hỏi thảo luận cùng với thầy. Chúng ta sẽ có khoảng độ 10-15 phút thảo luận, sau đó thì Professor Kinbai sẽ trình bày bài tiếp theo. Mời bác sĩ Đông ạ, mời anh Đông ạ. Em chặn mic của anh. Bạn ngồi sau thầy Vin ấy.
Okay.
Anh nhắn được một lại rồi.
Trước hết giới thiệu tôi xin ông vì cảm ơn các ban tổ chức rồi cái thầy để đến từ nước Pháp để thế giới để giảng rất là hay. Thank you very much for your lecture. Excellent. We all here. Một câu hỏi là về vấn đề mà coarctation đó là cái vấn đề mà tức là trong thường ngày mình rất là hay gặp và mình gặp thường xuyên đặt ra câu hỏi là cái thai này có bị hẹp ở đầu chuỗi hay không. Còn các đúng đủ sự bất tương xứng là lúc nào phải đặt câu hỏi là cái thai này cái bị coarctation hay không, và cái chẩn đoán dương tính giả nó rất là nhiều, dương tính giả rất là nhiều thì là thì như vậy thầy là cái xác suất đó là 20%, 80% là thầy nói là thầy quý 2 là có chừng 20%, 80% là có thể có nguy cơ bị coarctation. Còn nếu quý 3 mà có sự bất tương xứng thì nguy cơ khoảng chừng là chưa tới 20%. Thì trong thực hành hiện nay thì các bác sĩ mà làm siêu âm tim thai cũng rất là khá nhiều và cái chẩn đoán dương tính giả là rất nhiều. Thì thầy có thể có những kinh nghiệm ngoài những vấn đề trình bày của thầy thì thầy có kinh nghiệm gì mà có thể mình làm hạn chế nguy cơ dương tính giả hay không? Tại vì nếu mà chẩn đoán dương tính giả quá nhiều những bệnh nhân ở Việt Nam ở những vùng rất xa xôi, họ phải tập trung về những cái vùng rất lớn ở vùng như là thành phố Hà Nội, bệnh viện Phụ sản Hà Nội rất là nhiều. Thì làm thế nào để hạn chế những nguy cơ cái chẩn đoán là coarctation hay không? Đó. Câu hỏi thứ hai thì là nó đơn giản hơn một xíu là hiện nay thì cái siêu âm tim nó phát hiện rất là mạnh ở Việt Nam, đặc biệt là những bệnh viện lớn như bệnh viện Phụ sản Hà Nội, bệnh viện Phụ sản Trung ương hoặc là bệnh viện Từ Dũ. Thì đối với những người mà bắt đầu làm siêu âm tim tại vì cái cơ sở tim mạch siêu âm tim người ta bây giờ mở ra rất nhiều ngay những cái vùng rất xa xôi, ví dụ như đồi núi hải đảo. Thì với việc kinh nghiệm làm rất là năm của các thầy thì thầy có thể cho biết là những cái cách nào là đơn giản nhất để có thể phát hiện được bệnh tim bẩm sinh hay không ạ? Đơn giản, tức là mình không nói chuyện guideline là mình phải làm tất cả các cách, nhưng mà những cái cách nào đơn giản nhất mà có thể phát hiện là tối đa nhất cái bệnh tim đối với những người với thực hành siêu âm. Cảm ơn.
Well, if I got it correctly, the first question was how to reduce false negatives in aortic coarctation. Nowadays, as I told you, there's no gold standard for that. You have to carry out this cardiac screening in the anomaly scan. And I'm not sure what is the procedure nationwide here, but you should carry out with 4-chamber view, both outflow tracts and traversal and trachea view. If you use also the traversal view with the color, this may lead to higher number of diagnoses, but I'm aware that fact that the color Doppler is not used everywhere in screening procedures. So, as I mentioned to you before, if you use the ventricular disproportion only as a tool, you diagnose 50% of the aortic coarctations. So you should try to get a better assessment of the upper views and especially traversal and trachea view in screening. So this means that the personnel of the GYNs involved in screening pregnancies should carry out those views. That's the only way for all the problems or the cardiac problems to be done. The second question was again how to increase nationwide the detection rate for heart problems, right? And again, to do that, you should aim to train in a proper way all the people here doing ultrasound in pregnancy. It has been shown repeatedly in France 30 years ago and just afterwards in UK with Lindsay Allen, that the way is this one. You carry out training courses in practice with the hands-on for all the people in regional centers where you carry out screening pregnancy, ultrasound in pregnancy, and that In that way, you end up with a higher number of referrals that should be centralized to these hospitals for final diagnosis and counseling.
I have a comment and a question for you too, actually, because you seem to know well the figures here. Just a comment in Necker, which is both a pediatric and a fetal cardiology center, the false positive rate, the afterbirth discordance between the prenatal diagnosis and the postnatal diagnosis is 16%, 1/6, having seen MFM, fetal cardiologist, and that's overall. And for the coarctation is a good representation of that. It's about 20 or 25%. So there is no way, I think, reasonably to go beyond that. But as Dario said, the training and the screening is the key for the heart, but also because IT seems to go much faster than medical training everywhere. What do you think of tele-expertise in those cases where if someone is far away from one of the big centers, how things could be arranged for having a sonographer on site and an expert from wherever, Hanoi or Saigon or Hue, to just give a good advice? What then should be shown to this expert?
Yeah, that may be an option, provided that at least for the fetal heart, the Wi-Fi and the signal transmission rate is decent, because otherwise it's very difficult and challenging to interpret a disruptive fetal heart sequence because of the affected transmission with Wi-Fi. Another direction is the AI, the intelligence, artificial intelligence, because nowadays there are several studies, brilliant studies, that have shown you that you pass with your transducer along the structure of the baby, and you have all the flashes and alarms going on and off to signal what's wrong. So both ways probably are in the future. Both will work. But again, you need a strong, very strong line for transmission for telemedicine for the fetus. That's for sure. Because otherwise, it's not like radiology, because in radiology, you have all the slides already there, and the expert can just interpret what he can download. But for the fetus and ultrasound, it's a dynamic process. So you have to have a very fast transmission. Otherwise, you cannot even lead the hand of the person there, because he will be 2 seconds behind.
Em xin cảm ơn bài giảng của giáo sư, rất là thú vị ạ. Em có 2 câu hỏi. Nó liên quan tới cái tiên lượng trong trường hợp song thai, 1 bệnh nhau, 2 buồng ối. Nếu siêu âm hình thái, 1 thai hoàn toàn bình thường, 2 còn lại bị bất thường tim, thế thì chúng ta có chọc ối để xét nghiệm gen cho 2 thai hay không? Hay là chúng ta chỉ có chọc ối cho 1 thai thôi, thai bất thường thôi? Đấy là câu hỏi thứ nhất. Câu hỏi thứ hai cũng liên quan đến tiên lượng. Thì trong trường hợp cũng như lúc nãy ấy, thì liệu cái thai mà nó đang bình thường ấy, thì cái tim thai nó có bị ảnh hưởng bởi cái thai bất thường hay không? Xin cảm ơn.
I need you to repeat what the issue of myoclonics. You said that if one fetus is affected and the other one, you have to terminate or you have to carry out fetal echo. Amniocentesis, yeah, okay. The risk of having a genetic conditions in the co-twin of the monodi is extremely low. So most of the patients will go for a single needling, but you should consider that in the discussion, because some may go for needling also on the other side. Okay. Oh, the second question was Okay, yes. Does affect the heart rate on the other one? I wouldn't say so. There's no reason actually for having an effect of one heart defect on the heart rate on the other one. It's more likely to have, if there is an imbalance in the flows, in the issue of TTTS or not TTTS, that may be an issue, but not for the heart. If you have an anomaly, also usually on the right heart in the monochorionics, there's no issue on the heart rate on the other side.
Xin phép thầy với các đồng nghiệp cho mình hỏi một câu hỏi này, thì vấn đề liên quan đến vấn đề heterodoxy, vấn đề isomerism, right isomerism hoặc là left isomerism, thì là hiện nay có đứa hiện nay ở những nước phát triển hoặc là nước Việt Nam chẳng hạn, thì khi mà mình có một cái chẩn đoán là bệnh nhân bị bệnh tim bẩm sinh mà mình nghĩ đó là cái đầu phân, đặc biệt là đầu phân phải, tức là nó không có lách đó, đầu phân phải, thì ở mình là hay cho chỉ định là chấm dứt thai kỳ. Rất hay cho quy định cái mức thai kỳ, thì không biết là ở hiện nay ở Care hoặc là ở những trung tâm tim mạch nổi tiếng của các thầy thì khi mà gặp vấn đề về bị đầu phân, đặc biệt là đầu phân phải, đối với những bệnh tim mà có thể sửa chữa được, thì các thầy có giữ được mà là các thầy có giữ không? Là câu hỏi thứ nhất. Câu hỏi thứ hai nó cũng có liên quan tới bệnh tim bẩm sinh nữa, tức là trong trường hợp mà bị đầu phân á, có một số trường hợp mình hay bị đau bệnh, cái là trường hợp là bị đau đầu phủ tạng, nó bị situs mà antaxis chẳng hạn, là colic, thì mình rất hay chẩn đoán nhầm là đầu phân, hay chẩn đoán nhầm với lại heterodoxy isomerism, tức là đảo ngược phủ tạng này, situs antaxis, mà hay chẩn đoán ngược lộn nhầm với lại là isomerism. Thì các thầy có kinh nghiệm gì để mà có thể mình những cái kinh nghiệm để chẩn đoán phân biệt giữa hai bệnh lý đó mà, giữa đầu phân và đảo ngược phủ tạng? Cảm ơn.
Thank you for your question. First of all, for the counseling determination, it is non-directive. So this means that you have to provide figures and what is the likely course of the intervention that the baby should have, together with your pediatric cardiologist and cardiac surgeon, if that's the case. And that it's the couple to decide whether to go for termination for left or right, or also situs solitus with a severe condition. This is the way we proceed, I think, all over Europe as far as prenatal counseling is considered. As for the condition that you mentioned, there is sometimes an issue in differentiating isomerism or cardiosplenic syndromes from situs inversus. By definition, when you say there is a situs inversus, it means that you do not have necessarily a heart problem, okay? You have some heart conditions, for example, corrected transposition of the great arteries, which may occur in situs solitus or situs inversus, and that's okay. But if you want to differentiate, it's a continuous spectrum, because you have isolated situs inversus with condition heart problems, usually not associated with the isomerism, and then you have isomerism, in which you have some of the features of the situs inversus. But for example, we had recently 2 cases in which you have a perfect situs inversus, and you have heart problems consistent with isomerism. So it's a mixture. The prognosis is made by A, the condition of the heart itself. That's a major issue. And B, you know that for situs inversus, there is a 30% risk of association with the saliopathy, with the Cartagener syndrome. And this may affect the lung of the baby and may lead to early demise of the baby with from lung problems, okay? And this, at least we mentioned that in our counseling, also for isolated situs inversus, because sometimes they do have major problems in this regard. So it's a continuous spectrum. You have not to focus how to call it, You have to focus rather to define the prognosis, and the prognosis 90% is made by the heart, and very minor percentage is made by the malrotation of the bowel, which may leads to to obstruction and to surgery for the bowel, but that's a minor thing.
Vâng. Xin chào các thầy ạ. Em là bác sĩ Sim đến từ Trung tâm Can thiệp bào thai. Hiện tại em đang phụ trách Trung tâm Can thiệp bào thai và cũng có một số cái trường hợp mà em muốn chia sẻ cũng như là để xin thêm ý kiến của các chuyên gia. Với những cái trường hợp mà song thai chúng em có một thai bất thường và một thai hình thái chưa phát hiện ra bất thường thì chúng em có xét nghiệm nước ối và đã có những trường hợp là chúng em lấy cả mẫu của hai thai, một cái thai bất thường và một cái thai chưa thấy bất thường hình thái, thì kết quả là một cái thai phù, một cái bất thường tim thì ra là tức nơ, còn một cái thai được có kiểu hình bình thường thì cũng ra một cái kết quả bất thường nhưng nó khác với cái kết quả của cái thai tức nơ, nó ra kiểu hình là 46XY nhưng nó mất đoạn nhiễm sắc thể Y. Vậy thì song thai chung một bánh rau ngày nay người ta có khuyến cáo phải là chỉ làm một cái thai nghi ngờ bất thường thôi không, hay là phải xét nghiệm cả hai mẫu ối để đánh giá cho cả hai thai? Bởi vì là chúng em đã gặp rất nhiều trường hợp là lỗi phân bào sau hợp tử, tức là dù chung một bánh rau nhưng mà cả hai thai sẽ có kiểu hình khác nhau hoặc là vật chất di truyền có thể khác nhau. Chính vì vậy thì sẽ không kết luận từ một buồng ối suy ra cho hai thai được, mà có những trường hợp chúng em vẫn phải làm sâu bằng những kỹ thuật rất sâu để có thể chẩn đoán được những cái bất thường rất nhỏ trên từng thai của song thai chung một bánh rau. Vâng ạ, em xin ý kiến của các chuyên gia.
Yeah, I agree. What I told you, what I told in my reply is that it has to be discussed, and in the overwhelming majority of the cases will not change. But our policy is to do in both. We propose in both, and then it's up to the couple to decide whether they go for one or two needlings.
Yes, thank you.
Thank you very much, Professor Paladini. Thời gian thảo luận của chúng ta đã hết, vì vậy thì kính mong quý vị là chúng ta sẽ dành các câu hỏi trong những buổi thảo luận sau. Ngoài trực tiếp ở đây thì chúng ta có 500 đầu cầu, khoảng hơn 500 đầu cầu từ tất cả các nơi. Thì các cái câu hỏi thì cũng rất mong là quý vị chúng ta đưa lên cái hộp chat trong cái bài giảng sau của các thầy để mà các thầy có điều kiện và giải đáp cho các cái thắc mắc của quý vị. Tiếp theo chương trình thì ban tổ chức xin trân trọng giới thiệu của Professor Mark Kinby. Please. Thank you.
Tiếp nối chương trình là bài giảng của giáo sư Mark Kirby, giáo sư về chuyên ngành